Okay, we'll get started. Hello, everyone. Good evening, good afternoon, good morning, wherever you're joining us from. Thank you for joining. This is Perspectives, a thought-led initiative by Kiwani. Today, we'll be talking about cost of quality in a laboratory. Quality is never an accident, but it is always the result of high intention, sincere efforts, intelligent direction, and skillful execution. That will help us understand more about quality and the cost of it in the laboratory, we have Professor Ashok Rathan with us today. Professor Rathan is a medical microbiologist by profession, and he was conferred the APJ Abdul Kalam Award for Lifetime Contribution to Medical Sciences in 2018 and Srinivas Oration in 2021 by Indian Association of Microbiologists for his contribution to laboratory diagnosis of tuberculosis. At present, he's an advisor in Pathkind Laboratories, and prior to that, he has held positions in academics, industrial research, public health, and diagnostic labs. Professor Rathan has published over 100 peer-reviewed research papers internationally, named in 30 international patents, guided over 40 doctoral and postdoctoral students, and authored the book Antimicrobials in Laboratory Medicine. Before I turn the stage to Professor Rathan, just a little housekeeping. Please stay on mute and don't raise your hands during the presentation. If you have any questions in your mind during the presentation, type them into the Q&A box into your Zoom control panel, and I'll bring up your questions during the dedicated Q&A session once the presentation is over. So you can keep putting in your questions, but we will bring them up towards the end once we get into the dedicated Q&A session. Now let's turn our attention to Professor Rathan. Ashok, thank you so much for joining. It's a great pleasure to have you with us today. I'm super eager to know what is the cost of quality in a laboratory. So let's get fired away.
Good afternoon, everybody. Today we'll deal with understanding the cost of quality in the laboratory. Diagnostics play a very important role in healthcare. They appear to influence at least 60%, if not more, of all the decisions that are taken in the hospitals. The total cost of lab tests may be only 3% of the total medical costs, but lab tests influence clinical medicine in diagnosis, in prognosis, in predictive assessment of patients, in prevention or monitoring of disease, in management of treatment. Then they influence public health, that aggregates of test results are used for disease surveillance, healthcare performance measurement, and quality improvement. And clinical data also provides new knowledge for innovation, evidence-based medicine, and improve clinical practice guidelines. For setting up an optimal laboratory systems, you require people, facilities, methods, and equipment, followed by training in standard operating procedures, use of quality control, and total quality management. This is supported by external assessment, strategic planning, and remedial action whenever required. The diagnostic cycle consists of a person deciding the test to be done, selection of tests, ordering of tests, sample collection, transportation, sample accessioning, analysis, reporting, interpretation, and back to the doctor. Now, this can be divided into 3 stages: the pre-analytical stage, the analytical phase, and the post-analytical phase. But the pre-analytical phase and post-analytical phase have also been added. so that now you have five phases of the diagnostic cycle. For everybody is worried about providing service, and service pathway of workflow is important. But before you start providing service, it is essential that these 12 quality system essentials are in place, because these are the pillars on which the quality of service will depend. Without the 12 quality systems essential, your lab work will be like a house on cards. Once you have the 12 quality systems essential in place, there will be reduction or elimination of medical error, likelihood to meet the customer satisfaction, potential for successfully meet accreditation assessment, and sustained attainment of quality objectives. There has been a sea change in our understanding of how to fix the problem. In the past, we used to feel that bad quality is because of bad apple. So we would try to identify the person who makes the mistake, blame him, shame him, and then get rid of him. But Deming, with his red bead experiments, indicated that if we take a ball which has 800 white beads and 200 red beads, 800 white beads indicating the correct process, while the red beads indicate process mistakes in the process, and give anyone a spatula containing 50 so that it can pick up 50 beads. Nobody will be able to pick up only white beads. That would mean that if there is mistakes in the process, no matter how diligent a person is, he would make mistakes. Medical error is a failure in process, is the fundamental difference. We can consider patient sample as an input, laboratory process, and then we get a test report. So a laboratory is connecting all these processes together. Most of the errors occur in pre-analytical stage, and therefore in any laboratory, if a person says my responsibility is only within the laboratory, then he's making a big error, because mistakes would occur if the sample is bad. So what is the definition of quality? Many persons have used different definitions, but overall, it is what is perceived as their needs. And the ISO standards say degree to which a set of inherent characteristics of a product or service fulfills requirements. The requirements have to be that of the customer. So what is it that the customer wants? Whether it is business to business or business to customer, the customer wants a reliable and reproducible results which are accurate and precise in clinically relevant turnaround time at reasonable price. If the laboratory is not producing results that are accurate, reliable, interpretable, and timely, that laboratory is a liability in the healthcare system and can do much harm. Reliable and reproducible results would be that each time you hit the target right. Duran had said that the reduction in variation is the evil. So in every process, we should try to reduce the variation. Variation is not, there are various influences, which influence the various factors which influence the quality, whether it is specimen, whether it is environment, the reagents, the test system, testing personnel, and they all can contribute towards incorrect results. So we need to pay attention to each one of them. In the recent past, the chemistry has improved so much that many of the tests can be classified as 6 sigma with very little variation. But there are still some tests which perform at much below that level. Normally, in our movement towards total quality management, calculating the quality cost is an important factor in that journey. Most of the labs, clinical labs, are at 4 sigma. That would mean that they would make more than 6,000 mistakes per 1 million opportunities and would use up 15 to 25% of their revenue in addressing these failures. Our attempt is to move the lab process from 4 sigma to 6 sigma, where there are very rare mistakes and less than 1% of revenue is lost addressing these failures. What really happens is that the profit gets small as a consequence of the cost of production, which also includes the cost of failure, and that is the waste. And if we can remove this cost of failure, then we can increase the margin of profit. Phil Crosby said, "Quality is free. It is not a gift, but it is free. What costs is the unquality things that we do, where we repeat tests, revise results, replace samples, and redo the work. All that cost money that we cannot charge." He also said, "Bad things happen on their own. Good things happen only when planned." So the cost-cutting mantra is to do it right the first time and every time. Anything else will cost more. The traditional thinking is that the value that we get from any service depends upon the output and the input. So the feeling is that if the input is low, then we would have more profit. So there is also a feeling that you get what you pay for. So meaning that if you want better service, you have to pay more. But recent research has indicated that new technologies that can reduce human failure, automation has reduced human errors, and delta checks and auto verification has optimized human resources time utilization. Thereby, if we act quickly and at the right time, we would decrease the amount of money spent, but increase the amount of money gained. In the process, you have the physician ordering the test, then the samples being collected from the patient, the correct sample being processed after registration, and then the report being ready. If every step is checked and the error is eliminated, the cost of error reduction will decrease. So the cost of quality could be divided into prevention cost, appraisal cost, and failure cost. Failure cost could be internal failure or external failure. In the prevention cost, that is making sure that we do the right thing right every time. This is the amount which is required the maximum and unfortunately is paid the least attention. The second part is appraisal cost. We seem to spend a lot of money in making sure that the results are right, but if the mistake has occurred, then the time and resources have already been utilized when we find the mistake. On the other hand, majority of the labs spend a lot of funds and resources to take care of failures, whether internal or external. There is a 1-10-100 rule, which indicates that $1 spent in prevention is equal to $10 in appraisal and $100 in failure. The prevention costs are those associated with laboratory activities specially designed to prevent poor quality in laboratory services from occurring in the first place. President John F. Kennedy once said, "The time to fix the house roof is when the sun is shining, not when it's raining." Periodic planning of quality goals and objectives, work process training and competency assessment, assessment of supplier capabilities, validation or verification of new or changed laboratory tests and processes, and quality management and improvement activities all constitute preventive costs and are essential for a functioning of a good laboratory. Our goal is to do the right thing right, first time, each time. That can only occur if everything is in place before we start doing the first test. We must be clear about what is preventive costs. These are for laboratory activities specially designed to prevent poor quality in laboratory services. For activities that prevent problems, error, or waste from occurring. They are not costs incurred to keep a problem or error from recurring. So if the problem has already occurred, then it is not preventive cost, it will be appraisal cost. The examples of preventable laboratory costs are preventive maintenance, maintaining your lab's instruments and equipment according to the manufacturer's schedule, ensures reliable performance and no breakdown. Quality planning, as the old army saying goes, prior planning prevents poor performance. Work process training and initial competency assessment after the persons have been trained so that they are able to perform the job well. These all will be preventive cost and should find their place in the budget. Our goal is to do the right thing right, first time, each time. Remember 5 P's: prior planning prevents poor performance. Coming to appraisal cost, appraisal cost is for evaluating quality of work after it has been performed. It is for measuring, evaluating, auditing to ensure conformance to requirements, to catch and correct problems and error before harm to laboratory users or patients. Some of the examples are ongoing competency assessment to ensure that staff maintains competence, calibration to ensure accuracy of measuring equipment, inspection of samples and reagents to ensure that the quality of input, that the sample is not hemolyzed, is not lipemic or contaminated. quality controls to run quality controls to ensure that testing methods are working and results are valid, and proficiency testing to ensure methods performance compares to peers, and external accreditations ensure lab performance to minimal standards. So the examples of laboratory appraisals are, this gives you the last chance to catch and correct before the report reaches the end user. This will include quality assurance, and there should be quality assurance program. There should be a quality control plan, and quality material is bought and used. Then we come to the failure cost. Failure cost is that cost that services that do not meet quality requirements the first time usually need a rework or correction. Failure cost could be internal failure cost, where the mistake is caught and corrected inside the laboratory before delivery of results or reports. And external failure cost is that when the mistakes are detected outside the laboratory by user who receive faulty reports, results, or other services. Examples of laboratory internal failure cost are sample problems, received sample do not meet acceptance criteria and need recollection, especially some tests which need to be done on fasted condition, or the sample has to come in frozen condition. Invalid instrument run when QC or calibration is out of control and results cannot be released. Expired reagents or material are not to be used in phlebotomy or testing. Anything that causes delay in turnaround time, like rework, retesting, repair, or downtime of equipment, is examples of internal failure cost. Examples of external failure cost is customer complaint when a customer is dissatisfied, report recall because of erroneous results, which are corrected and resulting consequences, misdiagnosis, cost of not receiving needed treatment and the cost of receiving treatment erroneously, not including patient distress, and lawsuits, which are uncommon but very costly when for whatever reason. So the expenses of rectifying quality problems, internal failure costs and external failure costs should be avoided as far as possible, and that is possible if we pay more attention to preventive and appraisal costs. So we should look at the cost of quality as two parts: cost of good quality and cost of poor quality. Cost of good quality means preventive cost and appraisal cost, and these should definitely be budgeted in the budget for the lab initially itself. And cost of poor quality is difficult to estimate, but it includes internal failure cost and external failure cost, and our aim should be minimize this because it is difficult to budget for poor quality. But if the lab has poor quality, then at least 25% of its revenue is wasted in addressing poor quality. Quality planning, training, making sure that the services requirements are established and met, quality management systems and quality improvement activities are all excellent examples of preventive costs and must be budgeted in any plan. Appraisal cost will be competency assessment of the staff, verification or checking of incoming material, process set and products, and quality audits must form part of appraisal cost and must be budgeted. Internal failure cost is because of unnecessary work, instrument downtime, and inefficiencies. Reworks such as rerun, recovering missing specimens, redraws, correcting data entry errors, and repairing breakdown equipment and failure analysis. All these will cost a lot of money to the lab and should be avoided. External costs are complaints, harm to the patient, corrected reports, and lawsuits, and should be avoided. So the impact would be that if the waste is removed, then profit will improve. And the waste and for preventive cost, the QC, calibrating material, PT program, internal audit program, external accreditation assessment, equipment maintenance and services, computer systems and training should all be budgeted. It's often said that we don't have the time to do it right, and that is why things go wrong. But if you look at it, if you work the right way first time, then you have to do only pre-examination, examination, and post-examination. If things go wrong, then along with that, you would have to do discovery of failure, immediate action, investigation, and report completion. And in some cases, you might have to do root cause analysis, corrective action, besides everything else. So if you don't have the time to do it right the first time, when will you have the additional time and resources to do it right subsequently? So as we move from external and eliminating external and internal failures and increasing prevention, we would find that the lab will become more lean lab, and errors and waste free services will be provided. The waste activities identified are many in the lab, waiting in the patients, doctor waiting, patient waiting, lab waiting for lab results, transportation, over-processing, supply management, motion, defects, overproduction, and misutilization of skills are all examples of waste in the lab, and we should avoid this waste as far as possible. We should also know that what we see is tip of the iceberg. There are many other errors which, if we start auditing correctly, we would be able to identify and get rid of, so that if we have good preventive and appraisal activity going, we will decrease our cost of failure, internal or external. But each time I'm stressing that you must budget well for prevention cost and appraisal cost. Most of the cost of running the lab is because that the cost of prevention is low, but cost of failure is high. And most of the labs have more failure cost and appraisal cost than prevention cost. On the other hand, if they can identify what is the total cost of quality and cost of implementing a quality program, they would find that by decreasing the failure cost and increasing the prevention and appraisal cost, you would find an area which is ideal, and that's where you would like to be. In the end, I would like to say once again, as Phil Crosby said, quality is free. It is not a gift, but it is free. What costs is the unquality things that we do, that is repeat test, revise results, replace samples, and redo. All that cost money. Bad things happen on their own. Good things only happen when planned. The cost-cutting mantra that I can give you is do it right the first time, every time. Anything else will cost you more. And finally, quality is never an accident. It is always the result of high intention, sincere effort, intelligent direction, and skillful execution. It represents the wise choice of many alternatives. Quality also marks the search for an ideal after necessity has been satisfied and mere usefulness achieved. Your watchword should be doing the right thing right the first time, every time. I thank you for your attention.
Well, thank you very much. So that was a good intro into the need for quality, especially the preventive ones. There are a few questions that have already come in. And so now I'm opening up for everyone else. If you want to ask any questions to Professor Ratan, this is the time now. So please use the Q&A box in the Zoom control panel that you will see on the bottom of your screen and raise your question. So the first question is from Sushma. Ashok, the question is, are there no human errors at all? Can every human error be attributable to process failure?
No, human errors will occur, but our aim is to train them. So if you first attribute every error to a human error, then you'll find that you're never going to improve. First is to make sure that the process is fundamentally right, and even then you'll notice that the more often than not, the persons will do it right. There are only very few exceptions where a person has to be reprimanded and relieved. Most of the time, the process, it's a mistake of the management in allocation of resources or choosing of the material that have chosen. So if you address yourself, if you do the root cause analysis of the problem, you would then be able to identify what was the root cause of the problem, and use a root cause analysis to find out the problem and fix the system.
Okay, so don't jump onto humans first. Look whether there's a process failure and then go to the humans to fix it. That's what you're recommending.
Yes.
Okay, some people are asking the questions in the chat window. It will be easier and in one place if you can please use the Q&A window. I think, Ramesh Kumar Gunashekharan. Can you please put in your questions into the Q&A window? Okay, so the next question is from Bharat Sharma. His question is, there are intangible impact on organization due to poor quality, mainly the image, perception in the market, and losing market share. Any reason why we are not discussing these aspects?
Well, those are the consequences, but those consequences, it's mostly because of perception, and but what is under your control is what you should be focusing on, to getting the things right, making sure that the results are accurate and reproducible and reliable, and they are delivered on time. Taking part in external quality assurance program and getting 100% score indicates that, and then that has to be done by any lab worker, not the best. When you get QA samples, you do not assign them to the best technician only. The aim is that they are to be treated as ordinary samples, and if you get them right every time, then there's the possibility that you're doing something right.
Wonderful. Okay, so there are a lot of people who are asking for the presentation. Please don't worry, we will share a copy of this presentation and we'll put it up on our website, which is kivani.in, and you can download it from there. And there's also a beautiful write-up which Ashok has shared with us. So we will provide that also along with the presentation. So just follow us on our LinkedIn, and then you will get to know when we are posting it, and then you can download it. Okay, back to the questions from Guru Raj Desai. What is the methodology for training the trainer?
Normally it is there. It depends upon the test that you're using. And there are 3 steps to it. One is that an expert should show the trainer how it is done. Then you should watch the trainer demonstrate to you how it is done. And finally, the trainer is left to it. And that is where you give the feedback and make correction till you are satisfied. After that, the trainer is left to train others. So a 3-step process, whatever is the technique to be used. One is that a standard operating procedure must be written down. It should not be in the mind of the expert. It should be written down in language that they can understand. SOPs are available and they can be used, but they must be made suitable to your own working, and written SOPs must be available at the site of testing, so that a person is not supposed to remember all the steps. You are at liberty to review and revise the standard operating procedure, and they should be available whether in electronic or written form at the site where the test is being done. That way you will ensure that persons all are following. And there should not be any discrepancy between SOP, what is written in SOP, and what is being done. And this is what has to be trained to the trainer. And the trouble with India is that we are full of persons who have 101 shortcuts. I think in the laboratory, we should encourage them to give their suggestions, and we should listen to their suggestions. But all work should be according to SOPs. And if their suggestions are incorporated into the SOP, then they should be rewarded. But the changed SOP, then everybody should follow. So just make sure that everybody does according. If you have to get reproducible result, no matter who is doing the work, whether it is 8 a.m. or 8 p.m., 2 p.m. or 2 a.m., if the results are going to be similar and reproducible, then you have to have same methods, and you have to test the competency of every individual in able to comprehend what is required and to implement the test that is entrusted to them.
Right. So listen to the shortcuts, but make it a part of the SOP. Okay.
Yes, if it is useful.
If it is useful, of course, yes. All right. So moving on to Pintu Bhattacharya. This is a very practical question. Sometimes it is not possible for small companies to follow Six Sigma principles. Then how would they prevent failures and maintain the quality? I think it goes to the root of saying, is Six Sigma only for large companies? Does it not apply to the small companies?
Well, it depends upon what, maybe small companies will do small things, but they'll have their involvement. The quality standards cannot change just because one is an international company and the other is a small homegrown company. Would you like to get an injection from an untrained person? If you break down every activity as a process, then just make sure the processes that you do are done the right way. And if there's no variation, then you would have less chances of making mistakes.
Wonderful. Okay, so there were a few questions in the chat. We'll just pick those up before I come back to the Q&A panel. One question is from Savita KS. Technology is developing and we have a lot of competition in the market. So given all of this, how do we assure quality? That's the question from Savita.
Quality is inbuilt into the new systems. They have now the new instruments will read the barcode, will know what tests have to be performed, will look at the barcode of the reagents and will not use expired dates. So all that is already built up. That would mean that humans have to stress more on pre-analytical, which is the most variable, and in post-analytical to make sure that the report reaches the right person in a manner in which he can understand and interpret. If he cannot interpret the results, then that is still of poor quality. You have to make sure that a person knows what is to be done once the report reaches him. And that's where pre-analytical about what tests are required, what is the preparation that a person has to undergo before this test is done, what would be the time that the test would be taken. I do remember about TSH, there was one person who would, TSH has a diurnal variation. So if you collect the sample at 8 o'clock, you'll have a different value. If you collect at 12 o'clock, you'll have different value. So in a healthy individual, and if a person is sick, then TSH, that is thyroid stimulating hormone, can go right out of the window. So if you want reliability and you don't want a person fighting with you, you need to make sure that the sample is corrected at the right time. So you need to pay attention to detail. Quality cannot come without paying attention to detail.
Great. So the next one is from Sanzida Chaudhary. I hope I'm just pronouncing her name right. The graph shows high quality requires high cost. How to reduce cost, ensuring high quality?
No, the cost of running a lab consists of preventive cost, appraisal cost, and failure cost. It is failure cost which eats up most of the budget, and it cannot be budgeted for. On the other hand, while your cost for prevention is very low, if you ask persons, have they been accredited? Are they taking part in quality assurance program? Are they running quality controls every day? Are they bracketing their clinical work with quality control? Most of them will say no. So they're cutting corners at the wrong place. And then when they have failures, then they're crying for high cost. You have to invest in prevention. If you invest in prevention, then you do not have to cry for high cost of failures. Failures will not occur. Failures occur because you have not taken the right preventive steps. If you take the right preventive steps, and that costs money. I'm not saying it doesn't cost money, but you will be able to charge 5 times more from the patient. But failure will eat up all the profits if you do not invest in prevention.
It's being penny wise and pound foolish by not investing into quality.
Yes.
Okay. Next one is from Ramesh Kumar Gunashekaran. Could you please give me a definition of redo or retests?
Oh, a redo or retest is when you suspect that something has gone wrong and you are retesting, which is not required. If it is not required and you are retesting, that means you are wasting your resources as well as time. Redraw would be if the sample is, if there's something wrong with the sample, either it is hemolyzed or it has got contaminated or it is lipemic or the quality is not sufficient.
Okay. From Baby Uma Maheshwaran Indra, all the factors affecting the quality of result is applicable to all labs. So being a food testing lab manager, I came across all these one way or the other. Okay, I don't think there is a question. It's more of a compliment. So it says, thanks, sir, and Kivani. Oh, so let me extend that, saying that, is it applicable only to the healthcare and the diagnostic setup, or it sort of spans into all other laboratories?
I think quality management system applies to all walks of lives, and there would be specific instances which would be different, but wherever there is a process, you would have the same phases going into the play.
Okay, great. The next one is from Do Kang. How does the calibration cost affect the quality? Could you explain more?
Oh, see, I've had this a number of times in many of the labs that I've worked, and it would be that the test which is used is not a frequent test, and normally it's been recommended that you do calibration every 3 weeks or so. So in calibration, you would have so you spend time in doing calibration, and then you find that there's no sample which has come. But if after 2 or 3 weeks a sample comes, then you test the results are out of range. Then you do calibration once again, and then so that would mean that the lab must decide what should be the frequency of what are the tests that they are doing frequently, and outsource those which are rare tests rather than waste on calibration. Another problem I noticed was that in one of the labs that we had, one of the junior most technician would come and open the lab, and he would then do the test. He would run the quality control. When he finds that the quality control is out of range, then he will do calibration. So for say 10 tests, he had done calibration about 20 times. So it is the calibration is essential step to calibrate the system, but it should be done at whenever the time has been indicated by the manufacturer. And you should support that along with daily QCs. And it's also best to do QC before you start clinical testing, and do QC after you finish for the day, so that if both QCs are within normal range, then all your results are reliable. Many places, they do QC in the morning, and it's only in the next morning will they know that the QC is out, and then they will have to retrace all the tests that have been done during the day to find out where the instrument went out of range. So clinical testing should be bracketed with quality control testing before and after.
All right. So there are two user choice questions because both are neck to neck in terms of getting their reports. Let me pick up the first one from DM Shams. The question is, in case of quality cost, sometimes promoters are not ready to invest. How to convince them in this case?
I guess if you do the calculation of in the paper that the handout that I'm giving out, that gives you on how to calculate the cost, and then you say, if a failure cost is this much, appraisal cost is this. Appraisal cost normally should come to about 10 to 20% of the total budget, and then a preventive cost should be again 20%. So 20% for preventive cost, 20% for appraisal cost. That cost will make sure that there is no place for failure. At the moment, appraisal preventive cost is 1 to 5%, 10% is the appraisal cost. The rest is all eaten up by failure.
Failure is more expensive than prevention.
Failure is more expensive.
Okay. The next user choice question from Chandrasekharan M. Regarding the third-party QC, frequent outlier occurs without establishing in-house lab. So the cost to quality increases. How to address this? Is the manufacturer's QC run in parallel acceptable? I think the question is more in terms of if there is a third-party establishment doing these lab-related activities, how to establish and control the quality measures.
Yes, but see, even if it's third party, then third party will be giving to hundreds of users. If you take part in College of American Pathologists program, they have about 10,000 participants. So they would then analyze according to the instrument that you're using. I used to indicate that if they have 4 or 5 instruments and the instrument we are using is not one of the instrument listed, then either we are a thought leader or we're doing something wrong. If the world is using, and we have good lab, CAP accreditation, quality control costs a lot. So if you are aiming for that kind of quality, you would be using instruments which will give you that kind of reliability. And if your instrument doesn't match into one of the 5 that are listed, then there is a problem somewhere. So as it is, that means you have chosen an instrument which has not been proven to be as reliable as the others. So the problem might start with that. Then you have to have your lab mean. Once you have your lab mean, then you would be able to see whether your results are matching or not, and where you fit in would be another. From instrument to instrument, there is some variation. So that needs to be taken care of.
All right. So the next question is from Morlai Kareem Kamara. And the question is it advisable to use expired reagents after validation?
Expired reagents can only be used for training purposes, for trials, etc., but not for patient care. You see, there are many factors which go into giving the expiry date of the reagents. Just because it's working fine now doesn't mean that it will continue. What normally happens, there are various parameters and we're not testing all the parameters. So I think we should not this is false attempts to see that just because it has worked fine, just because the results are within range, the expiry date can be extended. No, you do not extend the expiry date, and you must have the discipline to use the reagents within the expiry date. For clinical purposes, for training, for others, that is when you're showing them how it is done. For demonstration purposes, you can, but it should be clearly marked and should not be in the same refrigerator as the reagents to be used for clinical purposes.
Okay, so you can still save on some cost by using them for training. Okay, Vibhuti Maru, the question is, there is often confusion between corrective and preventive action. Once an error has occurred, can you take preventive action for preventing recurrence?
No, that is then you're doing correction. Once the error has occurred, then it is a correction of the error that has occurred. So then you have to do root cause analysis on why the error occurred, and it might lead you to a root cause which you need to address.
Okay, great. So we've got a few minutes left on the clock. I'll just pick up the last 2 questions. And before we say goodbye to you, Rishabh, the first one is from Kakuli Banerjee. The question is risk assessment regarding lab analysis can be considered under preventive cost?
Yes, I think that is when you set up the lab, then you do risk analysis of where are the risks, what are the chances of error occurring, what controls need to be, that is of setting up the processes. So that will be part of preventive cost. And in the West, I think instead of having same QC for everything, they've had the QCs changed according to the risk assessment. If the test is so robust that it will give you the same results every time, then you can decrease the number of QCs that you run. While if the result is variable, then it should be controlled by frequent QC.
Okay, the last question for you is from Sumati Muralidhar. Any tips on improving the accountability of technical staff in quality improvement of a laboratory? I see a smile on your face.
I think it's motivation, because ultimately, Sumiti is we've known each other for some time, and her husband and I, we were colleagues, and she's a very sincere worker, but she works in a government setup. I work in a private setup. The difference, of course, is motivation. I think if you motivate if you can find what motivates the staff, and I agree that in India, money seems to be an important motivation, not punitive motivation. If you can give them, if they perform well and you give them some bonus, then that's a good motivation. But sometimes it's the ego also which is important. So I guess what is required is to work on, to find out what motivates the individual, and to see how you can pump them up to do the right thing right. But ensuring that they stick to the SOPs will make sure that that the results are right.
Okay, that's splendid. So I think there are a few more questions that has come in, but given the paucity of time, we'll take it up offline. Ashok, I just wanted to let you know that there are so many messages thanking you for a wonderful presentation.
Thank you.
People from all over the world. I didn't want to, sort of tell that to you every time it was coming in, because it kept pinging. Thank you, thank you, thank you, thank you, thank you. I don't want to derail your train of thoughts, but I think you should be aware of it. There are so many people around the world who are absolutely thankful for what you have delivered today.
Thank you.
Yeah, and so from Kiwani, all of us here, and from Perspectives, this is a great addition to our Thought Leader initiative. This is going to be staying on YouTube, serving a lot of people for a long time to come. So thank you so much for being with us. It was great having you, and great having all the participants. There have been many requests for the presentations. Guys, folks, not just the presentation, you will also get a copy of a beautiful write-up Ashok has done regarding cost and quality. We will be putting it up on our website so that you can download it. Just follow us on a social media channel, and then you will get to know when we are publishing it. With that, thank you very much for making the time to join us today. We'll see you in the next edition of Perspectives, a Thought Leader initiative by Kiwani. Thank you, Ashok, and thank you, everyone. Cheers. Bye-bye.